Hi, today I will be discussing a study titled Virtual Reality Exposure Therapy for Social Anxiety Disorders, a randomized controlled trial. In past studies, several advantages of VR exposure have been noted, both clinical, such as treatment acceptability by many patients who may otherwise avoid treatment due to the nature of the illness, as well as methodological advantages, such as the ability to hold therapy in tightly controlled environments. Many studies also conclude that it is as effective as real-world exposure and more effective than waiting list control. This study suggests there is a lack of research comparing VR exposure treatment to exposure group therapy and aims to compare these two types of treatment to each other and waitlist therapy. Importantly, the study claims that the two treatment groups were designed to be as similar as possible, with the exception of the modality for the delivery of exposure. It is hypothesized that relative to waitlist, those receiving treatment will improve on standardized measures of public speaking fears and fears of negative evaluation. Participants are also expected to maintain treatment gains at 3 and 12-month follow-ups. Let's look at some of the ways results were measured. Standardized self-report measures were collected at pre-treatment, post-treatment, and 12-month follow-up. Process measures were also collected by therapists during treatment. Public speaking fears were self-reported using the personal report of confidence as a speaker. Social anxiety disorder symptoms were self-reported using the fear of negative evaluation, brief form. Ratings of overall improvement were measured using the clinician global impressions of improvement. 97 participants aged between 19 and 69 with an average age of 39 who met Diagnostic and Statistical Manual of Mental Disorders criteria for a primary diagnosis of social anxiety disorder and self-identified public speaking as their primary social fear were randomly assigned to VR exposure therapy, exposure group therapy, or waitlist. I would now like to address a number of differences in the methodology between the two treatments. Virtual reality exposure consisted of 4 30-minute sessions conducted by 2 therapists, while exposure group therapy consisted of 6 20-minute sessions conducted by a licensed clinical psychologist. Virtual environments varied, consisting of a conference room with 5 audience members, a classroom with around 35 students, and an auditorium with 100 audience members, while exposure group therapy consisted of a maximum of 5 participants. Therapists could manipulate virtual audiences to make them appear interested, bored, supportive, hostile, and could even interrupt them with ringing phones or comments such as, "Could you explain that again?" Exposure group participants were required to provide only positive feedback to other participants. Now, virtual environments were also manipulated according to the participants' fear hierarchy, whereas exposure groups all received the same treatment. Considering the rationale of this study was that it was the only study to compare virtual reality to group therapy, these differences make it very difficult for a like-for-like comparison. Looking at the results, a series of analysis of variance and of chi-squares show no difference in pre-treatment symptoms on measures like the personal report of confidence as a speaker or fear of negative evaluation across VR exposure, exposure group therapy, or waitlist conditions. However, post-hoc pairwise comparisons for post-treatment scores suggested that there was a significant difference between VR exposure and exposure group compared to waitlist. At 12-month follow-up, it is seen that participants showed significant improvements from pre-treatment on both measures. The study states that there were no differences between the active treatments on any process or outcome measure at any time, nor were there any differences on achieving partial or full remission. But the results on screen suggest that there were significant differences between treatment groups and the rate of full remission and in those still meeting full criteria for diagnosis of social anxiety disorder. As demonstrated, There is further work to be done in aligning and comparing these two treatment types, but perhaps the two treatments do not need to be as similar as possible and should each draw on their own strengths. A virtual environment does not contain human-to-human eye contact, just as a hostile audience and ringing phones in group therapy may be stimulus overload and counterproductive for some in lowering an individual's fear of public speaking. But as discussed in the paper, Virtual Reality Exposure Therapy of Anxiety Disorders, a review, both treatments can be effective methods of therapy. To this point, while we can see full remission rates appear much higher for exposure therapy groups, partial remission appears very similar in this study. And while those who still met full criteria for a diagnosis of social anxiety disorder are also significantly higher in VR groups, we see attrition rates throughout remain significantly lower for VR therapy. While the study says it is unclear why this is so, it may be that virtual exposure is an effective way to offer a form of treatment to those who may otherwise avoid it. Finally, not only was the sample size quite small, but almost 1 in 4 participants suffered secondary disorders. While sample size is a common limitation facing trials, future studies could focus more on specific samples that might then narrow down which treatment could be more effective in terms of partial or full remission for particular groups, or by simply offering the appropriate treatment that has higher rates of participants accepting and completing treatment. Thank you.